A very good evening, everyone. I, Dr. Kavneet Kaur, welcome you all who are joining us from around the world for an exciting webinar on neonatal cholestasis in the AIIMS webinar series under my scope. I now invite Dr. Venkat Iyer, Professor and Head, Department of Pathology, AIIMS, to introduce our guest speaker, Dr. Kalyani Patel. Sir.
Thank you, Kavneet. Good evening to everyone. It gives me great pleasure to introduce Dr. Kalyani Patel. Kalyani was one of our brightest residents from the mid 2000s when she did her junior residency with us. And she was very famous because she did a thesis in molecular biology with Dr. S.K. Panda, who was the doyen of molecular pathology in our department. And she was one of those who got to work with him. So it is nice that I see she is still working in liver after all these years. Dr. Patel is now in the US. She works as a pediatric pathologist at Texas Children's Hospital in Houston. So Texas Children's Hospital is the largest children's hospital in the US and perhaps in the world, where they see 20,000 biopsies just of children. So she is interested in pediatric liver and pulmonary pathology and has special interest in pathology informatics. She has published on various entities in pediatric liver pathology like fetal steatosis in diabetic pregnancies, neonatal extrahepatic non-reticuloendothelial cirrhosis, mesenchymal hematomas of the liver, cystic fibrosis related liver disease, hepatic allograft steatosis, hepatoblastoma, where she has done a lot of work. So it's a highly specialized area in which she is involved. And it is nice that she is able to provide some understanding of this extremely focused area. She informs me that she wants to take a lecture which is focused on some of the more basic disorders which are there rather than some of the exotic. But I'm sure that she will cover many of the unusual entities which are in pediatric liver pathology very comprehensively. So once again, thank you, Kalyani, for agreeing to take this talk. I hand you the microphone to please deliver your lecture.
Sure. Thank you, Dr. Iyer, and I want to extend my gratitude to the entire organizing committee for giving me this opportunity to share some of the fascinating cases that I have come across during my years here in Texas Children's. A lot of what I will be talking today, the foundations of those things were laid during my training years at the All India Institute of Medical Sciences in New Delhi. And so it goes without saying that none of this would have been possible without those strong foundations during my training years. So very grateful for this opportunity, and let us start with our cases. So I'll be sharing my screen here. Okay. There you go. So before we head into, the greater details of neonatal cholestasis, let us just understand the structure of the, acinus, the liver acinus, and the basic histology that we will be looking on the slides on the liver biopsy. So here is a portal tract with a portal vein, a hepatic artery, and a bile duct. And what is important is that the blood flows from the portal vein and the hepatic artery into the sinusoids to the central vein and then out of the liver. So the direction of the blood flow is from portal to central, or zone 1 to zone 3. And in contrast, the bile flows from these hepatocytes, so conjugate, produced inside the hepatocytes, released by the hepatocytes into the canaliculus, flows through these canals of Herring into smaller ducts and into a portal duct, and then finally from the extrahepatic biliary tree, gallbladder, into the duodenum. And so the flow of the bile is zone 3 to zone 1, And in a normal state, these two are watertight compartments and do not mix with each other. With this, let us understand the definition so we know what we are talking about. So the title is neonatal cholestasis, and neonatal cholestasis in this context means conjugated or direct hyperbilirubinemia, which is increased conjugated bilirubin, greater than 1 milligram per deciliter when the total is less than or equal to 5, or greater than 20% of the total when the total is greater than 5. So this is sort of generally accepted as the definition of conjugated hyperbilirubinemia. At any age in a newborn period, this is pathological. This is not normal. So elevated conjugated bilirubin at any age in a newborn period is not normal. Physiologic jaundice of newborn is something different. It is indirect hyperbilirubinemia, typically seen from day 2 to day 5, and it usually resolves over time with or without supportive care. So this is a busy slide, and I know, not many of us like the biochemical pathways and, just kind of want to learn them only as and when required. So we'll get this out of the way, but this is crucial to understand what we will be, the cases that we'll be looking at today. So red cell destruction, increased heme protein catabolism, and ineffective erythropoiesis. Essentially, these are the major categories that give rise to increased production of heme, further converted to biliverdin, circulates in the blood as unconjugated bilirubin. This is taken up by the hepatocytes, converted to conjugated bilirubin, which then flows from the bile ducts into the extrahepatic biliary tree, into the duodenum, unconjugated by the intestinal flora, and then taken up again by the enterohepatic circulation. So as you can see, increased conjugated bilirubin here can happen when there is an obstruction to the extrahepatic biliary tree, or there is an obstruction within the liver itself. So extrahepatic and intrahepatic cholestasis, sort of like the two big categories of neonatal cholestasis. In 1961, we barely had any, very many entities for infantile or neonatal cholestasis. And you can see from that to, this was published in 2014, we have significant expansion from those 4 entities in 1960s, 70s to a huge laundry list of entities that can cause neonatal cholestasis. What is important to note that the biggest contributor to neonatal cholestasis still is biliary atresia. And so, fundamental understanding of neonatal cholestasis is not complete without truly understanding what biliary atresia is and how it can present to neonatologists, to interventional radiologists, to us as pathologists, and to the surgeons. So let's jump on to our case. First case, this is a full-term baby girl. She presented at 3 months of age with jaundice and acholic or pale stools. Infectious workup was negative. This is not a sick child. So this is very important to note. It is not a sick child. And ultrasound shows gallbladder and common bile duct not well visualized with a homogeneous parenchyma and no intrahepatic bile duct dilatation. Labs showed mild elevation of liver enzymes, elevated alkaline phosphatase, and elevated GGT. So elevated GGT is also very important. As you can see on day 1, direct bilirubin was not high, total was mildly elevated. On day 5, we are starting to see that the direct bilirubin is this is flagged by the lab, so it is elevated, but still it is not 20% of the total because 20% of 15 should be 3. It is still not 3, but certainly elevated. But at 3 months, it is clearly significantly elevated and, more than 20% of the total. So with this, we get a liver biopsy on this 3-month-old child. So here is a portal tract. We have a portal vein. We have a hepatic artery, and we barely have something that kind of looks like a bile duct, but it is very reactive and not very clear. What we see here is diffuse portal edema and mild mixed inflammation in the portal tracts. We are also seeing some tracts with bile plugs. So here is a bile plug in the bile duct, and here are some bile plugs in the peripheral ductules or in the ductular reaction. Some other areas show significant ductular reaction, also called ductular proliferation. Some people call it neocholangioles, cholangiopathy proliferation, many names, but essentially what it means is that you have proliferation of these duct-like structures along the limiting plate. And this is highlighted by CK7. So CK7 is one of our useful immunohistochemical markers for this. Can be identified on H&E. You don't absolutely need CK7, but it helps to highlight the ductular reaction. What is important in the lobules? So when I say lobules, we are essentially talking about the parenchyma that is between the portal tract and the central vein, and those are called lobules. So what we are seeing in the lobules is cholestasis. There is canalicular as well as hepatocellular cholestasis. And importantly, the lobules are not inflamed. So this is bland cholestasis. As far as fibrosis, trichrome is a good stain for fibrosis, and we can see portal fibrous expansion here. At 3 months, one should see good amount of portal fibrous expansion with occasional bridging, but fibrosis, the extent of fibrosis can depend on the age. And in very early biopsies, fibrosis can be kind of low or minimal, and actually that can be deceptive. So knowing the age to interpret fibrosis is important. So once we see all these features, and with the clinical, what we have where gallbladder and CBD was not visualized, GGT is elevated, what we are going to say on the pathology report is that features are consistent with extrahepatic biliary obstruction. It is important to understand that we are not really calling this BA, and a thoughtful clinical team should also not call this BA. What we all understand is what we are seeing on the biopsy are features of extrahepatic biliary obstruction. And by saying that, what we are essentially doing is we are buying the patient an intraoperative cholangiogram. So that is the sort of the next logical result of this kind of a biopsy report. And what intraoperative cholangiogram does is they essentially inject a dye into the gallbladder, and they look, this is a radio-opaque dye injected directly into the gallbladder. And this is a normal cholangiogram that shows draining of the dye into the duodenum and up into the liver, right and left hepatic ducts. This is a non-draining cholangiogram that shows drainage of the dye into the duodenum, but there is some pooling of the dye at the cystic duct junction, and we don't really see dye going up into the liver. This is another example of a non-draining cholangiogram where all we are seeing is pooling of the dye at the injection site, but there is no drainage either into the duodenum or up into the liver. And roughly in our BA cases, we see this in about 30 to 35%, and this is a dominant pattern that we usually see. So once an intraoperative cholangiogram shows this kind of a non-draining pattern, that is when the child is taken up for a surgical procedure. Usually can even happen in the same setting. At least that's how it happens here in Texas Children's. The procedure happens inside the OR with a team that is comprised of interventional radiologists who do this procedure. And if it is non-draining, then the PD surgeons come in and they will proceed with the Kasai Intrastomy. So there is no, need for double anesthesia. Just because we are talking about intraoperative cholangiogram, I think this is a good place to understand how this is different from a HIDA scan. So HIDA scan is actually intravenous injection of a radioactive material called HIDA. It is taken up by the liver and then excreted into the biliary tract. So you can understand for a non-draining HIDA, you could either have an abnormal liver or you could have an abnormal tract. And so many times diseased liver can show non-uptake of HIDA. So when someone says HIDA is non-draining, it doesn't necessarily mean BA. It could also mean that it was just not taken up by the liver, and that can classically happen with, neonatal hepatitis or any condition where the hepatocytes are not normal or inflamed. And so moving on to Kasai Intrastomy. This was a procedure that was introduced by Dr. Morio Kasai, who was a pediatric surgeon. And what he suggested is that if you transect the porta hepatis and attach a jejunal loop to relieve the biliary drainage in biliary atresia, then that can act as a bridge to transplant. So it's important to understand that Kasai procedure is not a cure-all for biliary atresia. It helps the patient to prolong the transplant. So it's a bridge to transplant. And studies have shown that early Kasai is important for longer native liver survival, meaning the earlier you do Kasai, the patient can have a longer period with his native liver, and the need for transplant, usually a successful Kasai transplants can happen as late as adulthood. This is how a Kasai intrastomy specimen should look like. It should, ideally, it should be obtained intact, and it should be, annotated correctly for the pathologist to sample. So typically what they will do is they'll take out a portion of the hepatic parenchyma from the portal plate as seen here. The right and the left hepatic ducts, usually I've never had, the fortune to kind of identify them really separately. I think they're very small and very difficult to identify separately, but a common hepatic duct certainly is visible, can be identified as such. You see the junction of the cystic duct joining the common hepatic duct, a very tiny portion of the common bile duct, and a hypoplastic, so mildly elongated gallbladder. We do a very methodical sampling of this Kasai specimen, obtain cross sections from different areas. And as you can see, again, a classic example of a biliary atresia case that shows fibroinflammatory occlusion of these extrahepatic biliary ducts at different levels. And we also usually try and correlate the pathology findings with the intraoperative cholangiogram, meaning if they saw drainage into the into the CPD, into the duodenum, we like to see patency of those ducts. And if the drainage was not seen into the liver, then we like to see that the common hepatic duct be nearly or completely obliterated. So we do that radiology pathology correlation on our Kasai specimens, or at least we try and do that for the key areas of obstruction. And this would be a classic lesion for biliary atresia. So as I said, our patient had presented at 3 months, and Kasai was done at around 90 days, which is slightly, this is on a later side. Kasai is done at 60 days or younger, do have a good chance of successful post-Kasai outcome. In this patient, as you can see, the liver is very green, which means it is very cholestatic, and it also has a very fine diffuse nodularity. And so this patient's jaundice was relieved temporarily, but then he presented with conjugated hyperbilirubinemia again, led to progressive cholestatic liver disease leading to explant at 1 year of age. And this is how the explant looks like. Here is that portion of, small bowel that is identified at the hilum. We try and take a good sampling of this area to make sure that there is no pathology at this KP site that may explain the obstruction or progressive cholestasis, and do a good sampling of the parenchyma per se. The typical sampling includes a generous sampling of the hilum and then central and peripheral sections from both right and left lobes. Microscopically, this is how one would see. These are, dilated ducts at the hilum. This is a large artery at the hilum, and this is kind of the perihilar parenchyma. And what you're seeing here are bile lakes at the hilum with fibroinflammatory reaction to the bile ducts. And whatever little parenchyma is seen at the hilum, you can easily see that There is micronodular cirrhosis with broad bands of fibrosis in between, ductular reaction, and bile plugs. Nicely seen again here. This is we are away from the hilum here, but essentially shows biliary type fibrosis with ductular reaction and bile plugs. Very classic for failed Kasai in a biliary atresia patient. Here are some other examples. This is patient who did not undergo Kasai. So this is untreated BA. Typically will need to have an explant will lead to cirrhosis in 6 to 9 months and will require an explant potentially even sooner. So understanding that the timing of Kasai is so important, this puts a certain amount of responsibility on the neonatologists, the radiologists, the surgeons, us as pathologists, rendering a correct diagnosis in a timely manner. And so at Texas Children's Hospital, we have a screening program for neonatal cholestasis. And what we do is we check the conjugated bilirubin at birth, which is less than 60 hours of life. And then we check it again at the first well-child visit, which would be around 2 to 3 weeks. And you can refer to these publications, real nice publications from our center here. And we have been able to bring down the median age at Kasai in our institution from 56 to 36 days. And you can see here an untreated biliary atresia would have increased conjugated bilirubin at birth, obstructive jaundice by 3 months, liver failure by 6 to 9 months, and death without transplant within a year. Without screening, being generally the average age for Kasai would be 60 to 90 days in that range, and usually will end up requiring a transplant at 1 to 2 years. With screening, we have been able to get down the age for Kasai. So we typically now are seeing early Kasai, early biopsies, which are extremely challenging, and early Kasais. And we have been able to prolong our transplant age. I think in our last series, our median age at transplant was around 8 to 10 years. And it is important to note that the native liver survival at 20 years and 40 years is very high in Japan, and there is a series from Italy, and I think for 20 years at least as high as 40 to 50%. So essentially half of the patients requiring transplant in adulthood, which is a huge success for biliary atresia. Prolonging the transplant in BA has its own enormous advantages. And so eventually, like I said, this is a bridge to transplant, and eventually these patients do need a transplant. So how does a liver of a successful Kasai look like? Because obviously with successful Kasai, the understanding is that your conjugated bilirubin is going to be normalized after Kasai, and it will stay normal in the post-Kasai course. It may show intermittent elevations during episodes of acute cholangitis, but essentially it is going to stay very normal till transplant. And so the most common indication for transplant in these patients is not cholestasis, but it is portal hypertension. And we did a good study recently on these patients with successful Kasai to look at their explants and to see how they differ from those with a failed Kasai. And as you can see, this liver looks so different from the liver that I showed you before. This is not green to begin with. It does not have this cirrhotic appearance. You have almost this perihilar, almost like a subtle nodularity, and then you have the peripheral parenchyma with some fibrosis sort of at the periphery, but largely non-fibrotic. And so this is a classic example of a explant with a successful Kasai. Again, as you can see, so this is the hilum with the bowel mucosa visible here from the right lobe and the left lobe, and there is barely any fibrosis. I mean, this is not biliary cirrhosis at all. In fact, what we are seeing here is a picture that mimics nodular regenerative hyperplasia. So what you have is this delicate fibrous septae that extend from the portal tract, complete or incomplete, with these regenerative nodules that are back to back, but without broadband fibrosis. So very classic for nodular regenerative hyperplasia. We also showed that within the portal tracts of these livers, you will see attenuated bile ducts, attenuated portal veins, barely visible, and mildly hypertrophic hepatic arteries with a sclerotic stroma, very classic for hepatoportal sclerosis. Note there is no ductular reaction, no bile plugs, no cholestasis within the parenchyma, and the extrahepatic portal vein shows fibromyxoid obliteration. And so the hypothesis here is that progressive portal hypertension is not because of cirrhosis or advanced parenchymal fibrosis, but because of obliterative portal venopathy. We cannot close BA without knowing other non-BA causes of obstructive cholangiopathy. These are uncommon, but can be observed in especially in tertiary care centers. Choledochal cyst, spontaneous perforation of the bile duct. There can be duodenal atresia. So the extrahepatic biliary tree is actually reasonably normal or patent, but the duodenum is atretic. That can give rise to obstruction. Can have a compression by an enlarged lymph node and neoplasms at the hilum. And so to summarize, clinically, typically we will have usually, again, this is usual, and obviously, deviations from usual do exist and make cases very challenging. But usually you will have a full-term normal pregnancy, and usually, again, this is not a sick child. And unfortunately, that is one of the biggest factors for delayed care in biliary atresia, because other than, just a jaundice, the child is otherwise many times eating well, active, no fever. And so it can take a little while for parents to realize the severity of this condition and get appropriate care. You have elevated conjugated bilirubin, elevated GGT, AST and ALT can be elevated, but usually not in thousands. On imaging, you'll see a small gallbladder. One has to be careful about small gallbladder because gallbladders can be often contracted in babies who have not eaten for a while. So if it's a sick child or a dehydrated child, you can have a contracted gallbladder, and so it should be interpreted in the right context. Non-visualized CBD, this can also, it is operator specific. So, other factors like movement of the child and, just other circumstantial factors should be considered for this. Triangular cord sign on ultrasound is a real good sign for BA, and plus or minus coarse ecotexture to the parenchyma depending on the age. For pathology, we'll see edema, mixed inflammation, ductular reaction, bile plugs with or without fibrosis, that is age dependent. Lobules will show cholestasis with either absent or relatively less inflammation compared to portal tracts. And what is important, it is as much an art as a science for biliary atresia. I have to say, it is a portocentric process, and so it's a relative weightage of where is the most activity. Is it in the lobules or is it in the portal tract? And so in BA, at least, it's a very portocentric process. We should also learn to differentiate from cholestatic injury leading to inflammation, because what happens is, as the lobules are cholestatic, meaning the hepatocytes are accumulating bile inside them, once the bile accumulates, they enlarge, they show feathery degeneration, and at one point they essentially, lyse or rupture. And now bile is very chemotactic. Bile is going to attract neutrophils wherever there is cholestatic cell injury. And so that one should differentiate that from inflammation leading to injury, which is true lobulitis. And so this really comes over practice, and as much as I can talk about minor differences, one just has to see many, many cases to and even then there is no guarantee it will be right 100% of the time. So close mimics are kids on total parenteral nutrition, neonatal infections, prematurity, alpha-nitrotrypsin, cystic fibrosis, Alagille, and combinations. So the most difficult combination that I have seen in my practice is a premature child on TPN and now suspected to have BA. Those are extremely difficult and really need multidisciplinary approach and understanding to make the diagnosis. There are several histopathology scoring systems. I think all of them have some value, but in the end, it is truly a multidisciplinary diagnosis. IHC is helpful, but is not diagnostic. And I think a good example is a recent paper from AIIMS Bhubaneswar, where they showed that CD56 is not really specific to biliary atresia and can be seen in other entities as well. Typically, a non-draining IOC, that is intraoperative cholangiogram, is considered diagnostic or a gold standard for BA. And I think for the most part that is correct. But one has to understand that it is a very operator-specific test. It is technically difficult and it has nuanced interpretation. I would really encourage, if you're serious about understanding this disease, please go to the interventional radiology suite, make friends with them, and please attend some of these procedures to understand how minor differences, even the position of the baby and how they move the baby while doing this procedure, can really affect the interpretation of this procedure. And so, just knowing that IOC was draining or non-draining, without context, I think it can help in a good number of cases, but it should not be considered something written on stone. So close collaboration is necessary, and non-draining IOCs have been reported in several other conditions. That should be kept in mind. So with this, maybe we can stop for a minute and see if there are any questions before I move on to other entities.
Thank you. Let me introduce the moderator for today's talk. It is Dr. Rajni Yadav. She is part of the GI pathology team, which is Dr. Prasenjit Das, Dr. Rajni Yadav, and Dr. Madhu Rajeshwari at AIIMS New Delhi. They do a lot of work on pediatric medical liver diseases like intrahepatic paucity of bile ducts, and also work a lot on hepatoblastomas. So please pose your questions on the chat box in YouTube, and Dr. Rajni Yadav will pose those questions to Dr. Kalyani. Dr. Rajni.
So Dr. Kalyani, we have two questions for you. So first question is, how do we access the diameter of the bile ductules on Kasai procedure specimen for prognosis? So do you do quantitation routinely, or are we supposed to actually do it quantitatively, or is it not necessary?
That's a good question, and I don't think there is a consensus on that. So you will hear different opinions based on who you ask. I used to do quantitative assessment on bile ducts in my early period, during my training and after, but I have stopped. So right now I do not do quantitative measurements on the bile ducts. And none of the other colleagues who I practice with, we do not do quantitative assessment. And the reason is, I think, so they are useful. I do think they have some utility to it. But as you can understand, this is a section of a tube. And so the diameter is going to depend on how perfectly perpendicular you're going to sample that tube. If the sampling is tangential, you're going to have difference in the diameter. So that's one. It's sampling dependent. And unfortunately, you cannot guarantee a very extremely uniform sampling in all the cases. So even if you do measurements, they may be difficult to compare between two or more cases. That's one. And we have realized over the years now that it is actually the histopathologic changes in terms of, the fibroinflammatory obliteration, the extent of, luminal occlusion. they matter a lot rather than, I would say they matter more rather than the actual numerical differences between the ducts. And I think the data on the actual numerical value of the duct diameter to determine prognosis is also not very robust. I think it is good data, but what happens is in the end, there are multiple other factors that end up determining the prognosis of a Kasai procedure than just the diameter of the duct. It's a long-winded answer, but I understand this is a question that even I have dealt with. So, yeah.
Yeah, so another question is that in the patients who are suspected to have this biliary atresia, so at what time intervals do you get the biopsies? Like pre-operative, intraoperative, or after some months after the Kasai operation? So what is the protocol there?
Oh, that's a great question. Okay. So number one, we don't have a protocol. I'll tell you typically what happens in our institution. So as I said, there is a screening. So we do screen for all our newborns to test their conjugated bilirubin levels within 60 hours of life. If they are normal, then they'll present. And if everything is normal, a normal discharge from the nursery, after birth, the baby goes home. Typically here in US, the baby will come back to the pediatrician at 2 to 3 weeks for the first well child examination. At that point, pediatrician is going to look for clinical evidence of jaundice, any dark urine, pale stools, scleral icterus, any yellow discoloration of the skin. If they see that, then at least here in Houston and surrounding areas in Texas Children's, I feel there is a real good awareness, and we have our PDGI docs have a real good collaboration with the community pediatricians, and there is I would say referral for those cases to our center is pretty good. These kids will then be monitored to see if there is anything else in their history that can explain cholestasis. And like example, neonatal infections, prematurity, anything else. If general investigations do not explain a reasonable cause for cholestasis, then an ultrasound examination is done. And if ultrasound examination shows abnormal gallbladder or a triangular cord sign, at that point, the kid gets a biopsy. I would say, if I have to average out, I think the average age for biopsy at our center is around 4 to 6 weeks. So that's when we'll get a biopsy. 3, maybe, I think in real good early cases, 3. So 3 to 6 weeks would be a good interval when we'll get a liver biopsy. At liver biopsy, like I said, if it is BA, if we think it is extrahepatic obstruction, IOC, Kasai. Post Kasais, we do not do biopsies here. No biopsies post Kasai. They are just monitored clinically, and they will show their course. It will be a successful Kasai or it will be a failed Kasai, and time will tell. And then when it comes to time for transplant, that is the time, or at least post Kasai, we do not do protocol biopsies. So that doesn't mean somebody might present with some unusual things and may end up having a biopsy, but not as a protocol. And so when it comes to time for transplant, at that time, they may or may not have a pre-transplant biopsy. Usually, if things are very straightforward, like, it's just a failed Kasai with progressive increased conjugated bilirubin, everything fits in terms of imaging showing a nodular liver, portal hypertension, splenomegaly, thrombocytopenia, everything is consistent. They will just get a transplant and the native liver will be out. And that is the opportunity to look for the native liver. And then, of course, post-transplant, there is whole series of allograft biopsies.
So we have another question for you from Dr. Mukul Vich. So he does a lot of pediatric liver pathology and a lot of transplants also. He works in Rela, this hospital with Dr. Rela, who is a famous transplant surgeon all over the world. So do you use Myo5b staining? Is there any role or use? on all cases or some selected cases?
Good question.
Myo5b staining.
Myo5b, yes.
Yeah.
So I have a slide on that and I'll show you. Short answer is no, we do not stain for Myo5b on a routine basis, but we do have this stain for some of our research projects in our research lab, but not done on routine basis. And
just a last quick question. Do you routinely use scoring system on all biliary atresia cases? Is it essential? So, or are these for for research purposes we have done, but routinely we are not putting up in the report. So is any scoring system essential to put up in the report?
Yeah, no, we do not do it because, again, I think it's interesting to look at scoring systems. I think they are really important for trainees and early practice pathologists, because it helps you methodically go through every criteria and helps you sort of develop a very standardized uniform way for assessing biopsies. But then there is a very delicate balance that we don't want to tip off, because we do encounter cases where low score, you can have both a low score with BA or a high score without BA, falling in either categories. And so we do not want our clinicians to rely on some kind of a cutoff. That is our reason for not doing this course. Because what happens is, once you start putting this course out in your reports, then there is a tendency for at least some physicians or clinicians to say, okay, score greater than this, that's it, this is BA, we are, we are going to call BA. And the nuanced discussion or some of the nuanced findings behind those that go in the interpretation of these biopsies are sometimes lost with just this black and white scoring. And so that is why, we don't put it out in our reports. We encourage our residents definitely to go through these scoring methodologies, and to have their own understanding of how they, and ultimately what I showed in terms of portal and lobular, it is these scores just in a different form, in a more subjective form.
One more question, please. So please explain how to gross a post-Kasai specimen from one of the attendee. Because like you showed a nice specimen, which was all intact. We receive sometimes just in pieces, different, and can't make out actually where is the duct, where is the gallbladder and everything. It is so small that it is hardly identifiable for a junior resident.
I am so glad somebody is asking this question. And, so our paper actually is under review for this. And unfortunately, this has been a very contentious issue, not only, maybe in India, but I think everywhere, And so because on one hand, we are, like you saw this picture I showed, we are very fortunate to have these kind of intact specimens coming from our PD surgeons. But I can tell you, there has been years and years of very close collaboration now that has led to these kind of really good intact specimens. We have spent countless hours calling our PD surgeons in the grossing room, kind of making them orient us to which is which. And, and we have had multiple, meetings, Zoom calls and everything to show them how the pathology slides then look like, how the gross specimen looks like, what was seen on IOC and things like. So I regularly, for every Kasai surgery, currently, once the specimen is received, slides are ready and I'm almost ready to finalize the report. Before that, I have a Zoom call with the interventional radiologist, the PDGI doc and the surgeon to go over everything and to make sure we are all on the same page. I think close collaboration really helps, showing them, what is ideal and what we should aim for really helps, because I think they really appreciate the feedback. They want the feedback, and we should not hesitate to give that feedback, to them. We would appreciate if anybody was giving us, a feedback to improve our practice. So I think it applies to them. And our paper, like I said, it's currently under review, should be out soon. But it's nothing too complicated. I think it's just common sense. So what we used to do in our center is we used to sample them. And like you said, these are millimeter size specimens. You're talking about a millimeter or even sometimes less than a millimeter tube that you're going to transect, and then hope that next day histology is going to embed it correctly and not on the side. And even we have had examples where we had to melt the block, rotate, re-embed, and look for the lumen. And if you don't see the lumen at that point, you don't know if it is wrong embedding or truly absence of lumen. And so that just puts everybody in a tough spot. So what we are doing right now at our center is we actually do not do very small cross-sectional sampling in the grossing room. We will just submit it in 2 or 3 parts. So for example, if we go back to this, the picture I showed, what we will do is we'll just submit this portion. We will maybe separate this out, submit this whole thing in one cassette, transect this, and submit this and this in one cassette. So essentially 3 cassettes. Next day, we will sit with the person who is cutting and embedding. And at that point, I sit with them, I cut, I lift the tissue, and then that person puts it in the hot paraffin. So we are sure that the lumen is face down, and what you're going to see is either the patent or the atretic lumen. We have had tremendous success, and I know it's very, it's unfortunately time consuming, but really there is no other good way to do this. And so, but we've had good success with that.
Thank you, Dr. Kalyani. So you can go ahead with your more cases.
Okay, wonderful. Thank you for all those questions. Okay, so we will move to another big topic. As you can see, biliary atresia, almost 50%, if not truly 50%. But this is extrahepatic obstruction. So we saw, how it can present, how the morphology is on the biopsy. So let's look at some of intrahepatic cholestasis and what it truly means and what will we see on a biopsy. So this is a 3-month-old baby boy presenting with jaundice. Note there is pruritus. And I know some will ask, like, how do you know a 3-month-old is, itching? It's such a small baby. But sometimes it's possible, I guess. Also important to know is that there was diarrhea and failure to thrive. Conjugated bilirubin is elevated. Total is also elevated. Important to note that GGT is normal. On ultrasound, gallbladder and CBD is well visualized and they appear normal. Again, this is not a sick child and basic infectious workup is negative. So here is the biopsy. The portal tract looks a little busy here, and I don't think we are really able to identify a good bile duct, but you can see a hepatic artery here and a portal vein here, maybe with a reactive bile duct somewhere here, maybe. But you're seeing canalicular and cellular cholestasis with occasional multinucleation. Inflammation is really limited to the portal tracts and the lobules are not that inflamed. Here is another portal tract where we are now seeing a portal vein, hepatic artery, bile duct is visible, and over here another profile, reasonably preserved. And what is more important on CK7 is that it identifies the bile ducts without significant ductular reaction. No bile plugs, not much portal edema, some inflammation, but not a whole lot. And this is electron microscopy. So for the sake of orientation, these are hepatocytes. Here is another hepatocyte. This is a hepatocyte nucleus. All these little round structures, the somewhat gray structures, these are all mitochondria. Here is a canaliculus, and here is a sinusoid with peripheral blood elements and Kupffer cells. And what you're seeing in the canaliculus is this sort of, coarse electron dense material. And you can, as you can see, not every canaliculus will have this kind of material. Some will show more normal bile, but this is abnormal bile. So on EM also, it is important to sort of go through the entire tissue that you have, because findings can be patchy. The same, some other areas showing beautiful coarse abnormal bile, also called Biler's bile. So based on these findings, we issued a report where we said there's mild portal inflammation, moderate lobular cholestasis. More importantly, again, these biopsies always come for rule out BA. So, we assure them that we don't think there is extrahepatic biliary obstruction. We note that there is Biler's bile by ultrastructural examination with no increased fibrosis. So with this, we suggest them, when we see this, we suggest them to do a genetic cholestatic panel. In this case, it showed a homozygous frame shift mutation in the ATP8B1 gene, which is responsible for PFIC1. So that was the diagnosis rendered by the genetic panel. This baby underwent explant at 11 years of age. So till 11 years, they essentially have, these are not rapidly progressive cholestatic disorders. They will have progressive cholestasis. They'll have pruritus, diarrhea, and it takes some time for, liver function, liver dysfunction. So transplants typically, at least in my experience, they'll happen in 10 to 15 years of age. This is how the explanted liver look like. I mean, no, there is, grossly, I was surprised in this case because there's not much cholestasis grossly and also not much fibrosis grossly, right? So many times actually in these patients, transplant will happen for intractable pruritus. That can be the indication for transplant. Microscopically, it's the reason I said interesting is because microscopically there is clearly cholestasis, canalicular as well as hepatocellular. And note how on CK7, so this is a very, very low power view of CK7 where you have this bile ducts only in one portal tract, and several portal tracts here do not show a bile duct. So atrophy of smaller interlobular bile ducts is a very classic feature of this entity, and fibrosis can be variable where, you have barely like stage 2, some bridging, to good bridging, to good nodularity, and all within the same liver. So peripheral areas are showing a little bit more advanced fibrosis than maybe the central ones. And so PFIC1, this is a progressive familial intrahepatic cholestasis with mutations in the ATP8B1 gene. It encodes for phospholipid flippase, which is located on the canalicular membrane and the ileal enterocyte membrane, and hence the chronic diarrhea part of the phenotype, and transplants are usually needed by 15 years. Moving on. So here we have a 2-month-old full-term baby girl, normal natal and postnatal course, intermittent yellow urine noted by parents, but otherwise healthy. Labs were mostly normal, but low GGT. Elevated conjugated bilirubin, again, not very high, but, definitely elevated at 2 months. Ultrasound is normal. Biopsy was planned for this baby, but bilirubin normalized in 4 weeks, and then there was not many issues, and we essentially lost this child to follow-up. And she presented again at 9 years with jaundice and intractable pruritus. And so this is the biopsy at 9 years. So technically, I know we are kind of off topic because topic is neonatal cholestasis. And so this is liver findings from much older age. But as you can see, it clearly can present as neonatal cholestasis. And in her case, bilirubin normalized, but not everybody will show normalization, especially in the neonatal period, and that can get sort of prolonged. So one can certainly get biopsies on this patient in the neonatal period. Overall, the architecture is well maintained. You're not really worrying about advanced fibrosis on this one. Significant cholestasis in the lobules. Note there is not much inflammation at all, just bland cholestasis. And here is an important finding of immunostain for BSCP, which is the bile salt export pump, which is completely absent in the biopsy, and this is a normal control. So normally in liver tissue, one should see canalicular expression of BSEP, and our tissue has complete absence of BSEP, which is abnormal. So based on that, we raise the possibility of PFIC2, which is progressive familial intrahepatic cholestasis type 2. This is because of the defects in the ABCB11 gene that encodes for BSEP. And what is important to understand here is that there is marked variation in phenotype. It can range from benign recurrent intrahepatic cholestasis, kind of just throughout the life without any significant dysfunction. You can have intrahepatic cholestasis of pregnancy. These patients often tend to have drug-induced cholestasis, and then some can certainly show rapidly progressive cholestasis, in the childhood. And phenotype depends on the specific mutation, usually confirmed by a genetic panel. And in this case, so when she presented at 9 years, as you saw, there's not much fibrosis, and yes, she did have pruritus, but it was manageable. And to this date, she continues to have intermittent jaundice and pruritus and has not required a transplant. I think by now she's around 12 to 13 years old of age and has not required a transplant. And in contrast, here is an example of a 3-year-old girl with the same disease but a different mutation, with advanced fibrosis. So, you can see here how much phenotypic variation you could have in this just one entity. What is also important, so early diagnosis is important for a couple reasons. One is, to know what to expect, at least based on commonly known mutations. You can sort of expect a certain degree of clinical course. And then also, these patients definitely require regular imaging. And the reason is because, particularly in PFIC2, children under 5 years of age have developed hepatocellular carcinomas. It is always better to identify them early with screening, rather than, catch late with lung metastasis. So this is a great example of a case where we knew the child had PFIC2. There was absolutely no issues with liver dysfunction per se in terms of, portal hypertension or decreased albumin or anything, but she was undergoing regular screening. And so per her PELD criteria, she would be very, very low on the transplant list. But at one screening, this lesion was identified based on the imaging characteristics and biopsy findings of this lesion, that it was an HCC. She got a significantly higher score on the transplant list, was eligible, and underwent transplant within a month of the diagnosis. So an extremely good outcome with successful screening and imaging of these patients. There are some pitfalls for BSEP expression. And so here are some good examples. So this is a 1-year-old boy with chronic liver failure of unknown etiology, abdominal distension, scleral icterus, osteoporosis, low factors, hypoglycemia. So he has, findings of liver dysfunction. As you can see, there is a significant lobular, sinusoidal fibrosis, some inflammation. And when we did BSEP on him, it was negative. However, the genetic panel came back normal for PFIC2. And so this was a very interesting case that we had where immunostain for FXR was negative. Normally, it should be nuclear positive. And so this was completely negative. And then this was diagnosed as FXR deficiency. This is an upstream receptor that regulates bile acid synthesis and transport and also regulates the expression of BSEP. So because of the FXR deficiency, there was deficient expression of BSEP on the canalicular membrane. So an interesting case and a pitfall for BSEP negativity. Here is a contrasting example where you do have canalicular expression of BSEP, but this is truly PFIC too. And so you would say, how come? Because, so the way some of the papers have explained this is based on specific mutations, because this is a big gene. And so specific mutations that may still keep the canalicular expression, but maybe reduce the expression. So that's one phenotype. There are other patients where the protein is present, but the mutation is in a different epitope than what the immunohistochemistry would detect. And then there are some cases with post-translational modification where the protein is expressed, but it is not functional. And so, important to understand that, yes, BSEP is definitely important, and I still believe we should do it despite these, diagnostic pitfalls, but it's not a tell-all answer in every case. So with this, we will move on to another case. And what I can do is after this PFIC category, we can stop and take more questions, if any. So this is a 2-month-old full-term boy presenting with scleral icterus and dark yellow urine intermittently since birth, but persistent since 2 weeks. So 2-month-old full-term jaundice. And now note there is high GGT. So high GGT, 2-month-old jaundice, you're really going to worry about biliary atresia. I mean, that's the first thing that should come to mind. However, normal ultrasound, examination, infectious workup is negative, and a biopsy was performed at 3 months of age at an outside facility. So here we have lobular cholestasis, is mild, canalicular cholestasis at 3 months. And it was called mild cholestasis of unknown etiology, portal tract. So by the way, I should have included an image of a portal tract, but there was no fibrosis, no ductular reaction, no bile plugs. So essentially they ruled out BA, and then they said mild cholestasis of unknown etiology. Jaundice was relieved by ursodeoxycholic acid, and the kid presented again at 1 year of age, again outside facility, and another biopsy was done at 1 year. You start to see, portal fibrous expansion. Still, it's not very diffuse, but focally pretty significant. Variable fibrosis, you're starting to see ductular reaction in some of the tracts. And actually at this age, they did worry on this biopsy, they did worry like if this was a missed BA. But otherwise, at 1 year, BA should have much more fibrosis. So compared to that, the liver dysfunction was not that significant. And fibrosis, even when it was present, it was sort of focal. There was elevated tissue copper. So clearly there was protracted cholestasis. And so the report was mild to moderate cholestasis, focally advanced fibrosis, and again, progressive cholestatic disease of unknown etiology. Because of the fibrosis, child was referred to TCH for transplant workup, and a patient was clinically stable. There was intermittent pruritus, but I don't think there was substantial follow-up at this point. And so presented again at 6 years of age with ascites. So at this time, we did a biopsy at TCH. So, and this is the time when we had an opportunity to review all the previous biopsies. So till this point, we did not have the previous biopsies with us for review. So when our in-house biopsy was done and we saw what we saw, that is when we requested all the outside biopsies for review. So at 6 years, you can see there's significant portal fibrous expansion, inflammation. Central duct is not clearly visible, and you're starting to see these very small ductule-like structures with bile plugs, constricted duct-like structures, kind of like ductular proliferation, but these are slit-like, very small duct-like structures without really a good identifiable central duct. The same here, again, marked portal fibrous expansion, small ductules with some bile plugging, but no central duct. We also had in some places bile extravasation, periportal bile granuloma, and hepatocytes are, yes, they're cholestatic, but very mild, no inflammation in the hepatocytes or lobules. So that's important. BSEP was preserved. Canalicular expression of BSEP is nice and normal, but there is complete loss of canalicular expression of MDR3. This is multi-drug resistant protein type 3, and this is a normal control where you should see canalicular expression of MDR3 in normal liver. So this was completely absent. Based on this, we raised the possibility of PFIC3, which is the progressive familial intrahepatic cholestasis type 3. This is a transporter of phospholipids. So in contrast to bile salts, this receptor transports phospholipids into the bile. This is the canalicular area for the hepatocytes, and this results in disease of the small bile ducts of variable severity and predilection to develop cholesterol gallstones. Again, clinical symptoms can be delayed until adulthood or pregnancy, and progressive, severely destructive cholangiopathy sometimes can be seen in young children. So as he presented to us at 6 years. It took 2 years for transplant to happen. I mean, clinically, he was still doing reasonably okay. So by the time he got listed and underwent a transplant, it was 2 years from presentation to TCH. And this is the explanted liver at 8 years of age. As you can see, the larger portal tracts actually are reasonably normal. You have a bile duct, you have lymphatics, hepatic artery, a portal vein, not much activity going on here in the larger portal tracts. There is some bile extravasation here in the periportal areas, but the smaller interlobular portal tracts and the ducts are significantly affected. There is clear loss or atrophy of these smaller ducts with bile plugging or extravasation, and also canalicular, sinusoidal, hepatocellular cholestasis in the parenchyma. So to summarize our PFICs, we have PFIC 1 and 2, which are essentially low GGT cholestasis that can present with pruritus. With PFIC 1 also has diarrhea as an important component. Abnormal bilers, bile by EM. This is a disease of the lobules as well as the portal tracts. This is a lobular disease, and this is a portal disease. Here, immunostains for BSEP can help, and here immunostain for MDR3 can help. One thing I forgot to mention for all this is patient will also have elevated bile acids. So that's also important to know in the laboratory or biochemical investigations. And so, I won't go into the details of these, some of these newer or uncommon PFICs that do exist. And like I said, I had a slide on Myo5b. So this is an immunostain that we have used in our lab, essentially on only on research projects. We do not do it routinely. I think you try to strike a balance between what do you want to do on a routine basis and the cost-effective analysis of doing those things. And so many times we need to justify that with our volumes. Fortunately, our center has seen a good number of PFIC 1, 2s, and 3s. And so these immunostains, we have been successful in getting them in our laboratory and clinically validated and do them routinely. And I would say if your lab wants to take a serious look at neonatal cholestasis and sees a good volume of neonatal cholestasis biopsies, these are real good immunostains to look at. BSEP and MDR3, I personally think you should have. These are very easy to validate, and they're just very helpful. TJP2 and Claudin-1 are for these uncommon types, and we don't have them. I mean, we have them in our research lab. We don't do them on a routine basis on all biopsies. We have occasionally only done them retrospectively after the genetic panel comes back with these diagnoses. So any questions?
So Dr. Kalyani, we have some questions for you. There is a question from Dr. Prashant Durgapal. So he is alumni of our institute. He has asked that how to differentiate the prefix versus neonatal hepatitis. So how much is the IHC for BSEP and MDR3 useful? Like for some types, we don't have these IHC in routine, TJP2 and all. So do you put IHC in all the suspected prefix or all on the neonatal cholestasis?
That is a great question. And we often struggle with that, on our side all the time. I'll have some slides on neonatal hepatitis. So to kind of go through some of the features of neonatal hepatitis, I think, okay, so let's go step by step. As far as the utility of BSEP and MDR3, I personally think, immunohistochemistry is not, yes, in the big picture, everything adds to the cost, but in the big picture, 2 immunostains are not going to change significantly the entire cost of your management. So especially in comparison to the amount of information that they are going to give you. So personally, I do incline in favor of using BSEP and MDR3 on a routine basis. And when I say routine basis, meaning slides where I don't think it is BA. So slides where now I'm entertaining other causes of neonatal cholestasis, I'm certainly not going to think too much before putting on BSEP and MDR3. So it really has become a knee-jerk reaction now. So that's one. So I do think there is they are useful. Okay, and I don't think you should have a very high threshold for using them. The question is interpretation. And that's also an issue here, because especially with BSEP, the problem is in neonatal hepatitis, the cells are injured, right? It is hepatitis. So there is inflammation, there is cell injury, there is edema, the cells are swollen. Because of all of that, the canalicular membranes of those cells are sometimes not intact. You just have so much cell injury that you don't even have an intact canalicular membrane. When you don't have intact canalicular membrane, at that time, loss of BSEP can be deceptive, because you need an intact canalicular membrane for interpreting the BSEP correctly. And we have seen that on our side. If you apply BSEP on heavily inflamed or injured liver tissue, you will get essentially a secondary loss of BSEP. Now, because we use it so frequently, we have learned to interpret it in that context, and we compare it with areas that are not inflamed and focus on those areas for the interpretation, and sort of ignore the inflamed areas as far as the BSEP interpretation goes. And then coming to the real distinction between neonatal hepatitis and prefix. So neonatal hepatitis is truly a lobular disease, or predominantly a lobular disease. And so I think it is easy to distinguish it from PFIC3, which is mostly a portal disease. I think it is reasonably easy. The problems occur with 1 and 2. And I agree that, it is easier said than done. But at least I would say on PFIC2, the amount of inflammation when I say lobular disease is a lobular disease, but it is lobular cholestasis. It is not lobulitis. And so the amount of inflammation in the PFIC2 is going to be much less than a classic example of neonatal hepatitis. The problem is neonatal hepatitis has such a wide spectrum. And so, these are just essentially words to explain little differences. When it comes to real practice, these do end up becoming challenging cases. And I think the challenge in neonatal hepatitis lies in ruling out entities that you can rule out by using techniques like this. And then in the end, when you have ruled out everything that you possibly can, using the clinical information you have, the immunohistochemistry you have, EM, everything, at that point you say, okay, it looks like neonatal hepatitis, sort of idiopathic or cause unknown.
There is another question, how to differentiate PFIC3 and EHBA. So like PFIC3 was also showing a lot of ductular proliferation. So there is this question from one of the attendee.
So fibrosis helps because, PFIC3, even though it is a portal disease, so both age and fibrosis help. Even though PFIC3 is a portal disease, at least in our experience, we have not really seen severe portal features, meaning, this like destruction of the bile ducts, bile plugs, ductular reaction, things like that in the very, very early age. We have not seen that. The general experience is that they can present, they certainly can present with neonatal cholestasis, but the severe portal features are usually much later. It is a slowly progressive disease with unique cases that can progress rapidly, but the general experience, vast majority of PFIC3 will not have a significant portal, affection in the neonatal, like the 2, 3, 4, 5, 6 weeks period. And then another important thing that helps is fibrosis. At least so far, in all the cases of PFIC3 that I have seen, they'll not have significant fibrosis at that very young age. Fibrosis is a slowly progressive thing in PFIC, and even in explants at 10 years, 11 years, actually we sometimes don't see that much fibrosis diffusely. So definitely fibrosis helps, age helps, and then obviously if you have the immunostain, MDR3 definitely helps.
So at generally what age do you get your patients of PFIC3? Like it is very heterogeneous. We face quite a lot of difficulty, and whenever we suspect, so they don't turn out to be PFIC3. At what age generally you get the PFIC3 patients? Because it has a wider age of presentation, I guess.
Yes, that's a good question. So whatever, these are uncommon things, but whatever I think I have seen around 10-ish cases of PFIC3 so far, and the typical standard age for presentation is 6, 7, 5, 6, 7, that years, not months, years.
Okay, so you don't see in adolescents like after 10 years and all, 10 to 20, that age group. So mostly they'll present before that.
See, the thing with PFIC is, so it takes that much time for them to become symptomatic. And typically they present, and that is when they'll present to us. What has happened, and that's why I don't want to, I think my experience here is a little skewed and may not truly represent what happens out in general practice because of the screening. Since we are aggressively screening babies for neonatal cholestasis, unfortunately, we are seeing, fortunately or unfortunately, we are seeing a whole lot of non-BA conditions that otherwise we would maybe not have seen, So I do think here, the experience here in our center is slightly skewed than, I don't think Many of these babies would end up having a liver biopsy in the general community setting. But because we have such an active screening program, I do think a good number of kids end up having a liver biopsy. So we do have some examples of neonatal cholestasis that incidentally and with our practice of throwing BSEP and MDR3 on every biopsy, or pretty much every non-BA biopsy, we have diagnosed it, you know. So us diagnosing PFIC3 at a young age is different from a patient presenting to you, right? So I think we only diagnose them because we actively caught them and biopsied them. But typically a patient will present at 5, 6, 7 years.
So as you told, so we also in the cirrhotic cases with or without cholestasis, when we put up BSEP and MDR3 IHC, so we have seen a patchy loss in many cases, like you told, because of the destruction of the canalicular membrane. So what we try ki when there is a complete loss of staining, then only we try to report as PFIC, as compared to whenever there is a patchy loss, and then definitely correlate it with the genetic panel. So is that a correct approach when there is a complete loss with presence in the control? So then we should suggest, so as compared to the other, in which there is a patchy expression.
I think that is an absolutely correct approach.
Okay.
Because otherwise we will be over-diagnosing them and the genetic panel will come back negative.
Yeah. And one thing you showed that EM picture. So do you get your tissue in glutaraldehyde, or did you do from the formalin fixed tissue in that case? Because routinely, do they send the liver biopsy tissue in glutaraldehyde in suspected cases?
So I do have a slide on how we triage and process our liver biopsies here in TCH. But yes, all our liver biopsies, we save a portion. They don't send in glutaraldehyde. They will send biopsy to us in fresh. Just moist saline telfa pad, fresh, and we have our triaging system, and all our liver biopsies, a small portion is saved for EM. We may or may not do EM. So what we do is our orders are embed and hold for EM, and will only request EM when relevant.
Okay, so you are not getting in formalin, you get them fresh. So that's why the quality was better, because when we try to do from formalin fixed, so it gets degraded. The tissue is too degraded to see on EM. And can you tell us about the genetic panel, which is essential at least?
Yeah, that's so
broadly which diseases. Okay, so you'll be telling in the next.
I have a separate slide on the genetic panel. I don't have all the genes listed on that slide. Maybe I should have, but the genes are available either in PubMed. So there are publications by academic centers who have their own panels, and most of them have published their genes, and private labs have their genes on their website. So I think, but actually, so the genetic panel is an interesting topic, because even now, I mean, even with the amount of biopsies we see here at Texas Children's, we don't have our own in-house genetic panel. We are actually currently working. I mean, my hope is that's currently what I'm engaged in, and my hope is by the end of this calendar year we will have a panel up and running, in-house panel. But so far we have been sending our biopsies out, blood out to private or reference labs, or even academic labs sometimes. And the panel that we are going to validate here in-house is going to be validated for both blood and paraffin embedded tissue, because especially on our consult cases, and we get a whole lot of consult cases, there's no blood, and all we have is just a block or paraffin embedded tissue. And so we want to validate our panel on that.
There is another question from one of the attendees. Can GGT help to differentiate neonatal hepatitis versus PFIC 1 and 2?
Yeah, I think that's a great idea, actually. And, you're right in the sense that typically GGT should be low, or we have had some examples where it was low normal in PFIC 1 and 2. So it was just borderline normal, not necessarily low. And so it's when in that normal range, sometimes neonatal hepatitis again can have normal GGT. But I agree with you, actually. That is a good point, that typically in neonatal hepatitis, GGT will be high, typically. And so, yes, I agree, it can help.
Thank you, Kalyani. I think you can go ahead.
Thank you. Okay. So we'll move on. I think we have covered like really the bulk of our neonatal cholestasis, but there are, as you can see, a whole lot of smaller entities, and they themselves form a big bulk, by themselves. And so and I don't think this, I'll be able to cover each and every entity in this lecture, but let's just look at some of them. So 2 weeks old, so remember, is very young, 2 weeks old, full term male and possible dysmorphic feces. Conjugated bile is elevated, total is elevated, GGT is also elevated. So based on this, again, biliary atresia should be very high on the differential. Dysmorphic feces is kind of odd, but we'll keep that in mind. We'll proceed. HIDA scan shows good tracer uptake by the liver, meaning most likely there is not much hepatitis going on, or the liver overall hepatocytes appear healthy. They have taken up HIDA nicely, but there is no clearance from the liver into the gallbladder or the duodenum. Interestingly, so clearly this is a it should keep BA high in the differential again, but normal ultrasound. So that's kind of odd, meaning they kind of saw a normal gallbladder and a CBD. So that's slightly odd for BA. Here is the biopsy. So this is a portal vein, hepatic artery, and something that kind of looks like a bile duct, but it is not the best in appearance. It is a little bit reactive, not nice and circumferential epithelial cells. The lumen is not visible, and there is kind of mild inflammation here. But generally not much portal edema or diffuse inflammation. Again, no ductular reaction, no bile plugs, so looks odd for BA. Within the lobules, you have these cholestatic hepatocytes that show this feathery change. This is a central vein, so zone 3 cholestasis. Whenever you see this, one of the things that should absolutely be noted in the clinical history or looked for is prematurity or peripheral sampling. So premature babies, their bile ducts are still developing, and this could be just normal in their livers, and because their bile ducts are immature, they end up having cholestasis in the early neonatal period. But it could be just normal and would hopefully progressively resolve over time if everything goes well. And then a peripheral sampling in a very young baby such as this, who is only 2 weeks old. So, we know there is a significant amount of peripheral bile duct development that happens postnatally, especially in the periphery of the liver. And, there's whole, you'll find many articles talking about to what age it continues. I think there is a good consensus that it certainly continues up to 2 years. And then there are some articles saying that the bile duct development actually even, extends way beyond that, but certainly up to 2 years of age. So meaning the peripheral bile ducts are still being laid down and still immature and developed. So on a 2 weeks baby with a peripheral sampling, this could just be a normal finding. So definitely, keep that in mind. Again, this is where a good collaboration with interventional radiologists should help, especially on liver biopsies. Rarely, it has become much less common now, but rarely when we have a liver biopsy with a capsule at one edge or somewhere on the biopsy, we will immediately get back to our IR team and will let them know, hey, this is peripheral, you need to go deep. So they know that there's going to be a feedback loop there. And so, I think that's how we help each other in making better diagnosis. So with that, and there was barely anything much on the biopsy. And so, we were kind of stuck here. The cholestasis, no significant fibrosis. We ruled out BA, BSEP and MDR3 were done, they were preserved. Nothing else was abnormal. But further workup in the child showed left pulmonary artery stenosis and butterfly vertebrae. So obviously with this, the diagnosis is Alagille syndrome, which is arteriohepatic dysplasia. Vast majority are due to mutations in the JAK1 gene. A small proportion can happen in, due to mutations in the Notch2 gene, which will have more severe renal disease. On pathology, we will see progressive intrahepatic loss of bile ducts. And note here in this biopsy, which was done at 2 weeks of age, there was no duct loss, meaning, all the portal tracts that we saw, bile ducts were identified, just that they looked a little reactive and not so normal, but they were not inflamed. There were no bile plugs. There was no ductular reaction. And then, there was also no, in this entity, there is no hypoplasia or atresia of the extrahepatic ducts. The lobular cholestasis actually surprisingly can be very minimal or absent, especially in the early phase. What is important for Alagille is that occasionally it can mimic BA significantly. And so this was a good article where we have a wedge biopsy at 6 months and a wedge biopsy, same patient, at 25 months. So at 6 months, you can see significant ductular reaction, inflammation, with this one may think of BA, and we have certainly seen it is becoming more and more uncommon. But historically, I'm sure, people in tertiary medical centers must have seen at least one example of an Alagille who underwent Kasai. So it's not that uncommon, it truly does mimic BA in many ways, at least in the early period, less than 6 months. So this is how it looked at 6 months, kind of mimicking BA, but at 25 months, the picture was much clearer, where at 25 months, now you have complete loss of ducts, bile ducts by CK7, no ductular reaction, no ducts. What is interesting, although, in this particular article at 25 months is that there is not much aberrant staining of the hepatocytes by CK7, which is kind of interesting because we have seen, at least I have seen, aberrant staining of hepatocytes by CK7 at this young age in Alagille patients. Now, I agree, admittedly, it can be patchy. So, it could just be sampling, but that is another helpful criteria with complete absence of ducts, absence of ductular reaction, with aberrant staining of hepatocytes by CK7, one should certainly think of Alagille. And this is just a collage that shows how explants can look different at different age. So, some are at 3.5 years, this is at 4 years of age. But see how fibrosis is still kind of limited. There's not much advanced fibrosis even at older age. And this is what I was talking about as far as the CK7. This is the aberrant staining of the hepatocytes by CK7, which, I see reasonably commonly in Alagille patient with loss of bile ducts. So progression to cirrhosis is rare. Liver transplant usually actually done for as maybe difficult as it is to believe, but pruritus can be so intractable. Sometimes they'll undergo, I just recently last week had an explant of an Alagille patient who underwent a biliary diversion procedure for pruritus. But even that didn't help and, ultimately required a transplant. Mortality is more actually related to cardiac abnormalities and, aneurysms, intracranial bleeding, and not so much dictated by liver pathology per se. And so this brings to the topic of paucity of intrahepatic bile ducts, which is kind of a big giant basket in itself. The normal ratio of bile ducts to portal tracts in full-term infants, children, or adult kind of ranges, 0.9 to 1.8, depending on the age, location where you are sampling, things like that. And duct paucity is when you see bile duct to portal tracts in less than, bile ducts identified in less than 50% of the portal tracts. That's when you'll call duct paucity, when adequate number of portal tracts are sampled. Syndromic paucity is allegial, and for non-syndromic, we have a huge laundry list of things, including infections. We can see this in GVHD or chronic rejection. Drugs can cause duct loss, inherited metabolic diseases, chromosomal defects. So trisomy 21, a good example. It could be just isolated idiopathic adulthood ductopenia that kind of just goes undetected overall, and you may be identified when a liver biopsy is done for something else, completely different. And it can certainly be a late feature in BA or sclerosing cholangitis, Langerhans cell histiocytosis, PBC. It can also be seen in alpha antitrypsin deficiency. So just a very, very long list for non-syndromic paucity. So with that, let's look at a few more cases. 5 weeks old girl presenting with elevated liver panel, conjugated hyperbilirubinemia, ultrasound was normal, and this is a sick baby. So that's important. As we saw, typically BA and even Prefix, for that matter, they don't really present with sick babies. And what I mean by sick is, it could have fever, not eating well, dehydrated, things, lethargy, things like that. Bile ducts were identified in 9 out of 20 tracts. So, certainly there is paucity by definition. You can see an artery, a vein, but not a bile duct. And note here, there is lobulitis. So this is an important finding. There are lymphocytes surrounding the hepatocytes within the lobules. This is not something that you would see typically, again, with Alagille or, PFIC, or BA. And so what you have is no ductular reaction, no bile plugs, not much cholestasis in the liver per se, but you have this, weird odd foci of lobulitis in the biopsy. There is some zone 3 cholestasis or giant cells, transformation, some feathery degeneration here. Whenever we see lobulitis in the biopsy, we always do immunohistochemistry for CMV, EBV, adenovirus. So all those immunohistochemistries were negative. However, the tissue PCR came back positive for CMV. And so I think the learning point here is that when there is lobulitis, when you have a sick baby, always keep infection high in your differential. Always look for infectious causes, and one single technique may not help. Like here, IHC clearly did not help us. And I have to say, generally my experience is until and unless you have viral cytopathic effect of CMV, the IHC has always come back negative. So, we keep doing it, but I'm starting to lose faith in that. So at least for CMV, serology definitely helps, and then tissue PCR positivity certainly helps. And so we call this, CMV related duct paucity and CMV related neonatal cholestasis. This is a 2 weeks old girl born near term. No maternal significant past medical history. Pregnancy was complicated by GBS, which is group B streptococcal infection, but the baby is not particularly sick at birth. Admitted for neonatal hypoglycemia, conjugated hyperbilirubinemia. Urine CMV is negative. Labs were normal. On ultrasound examination, they saw patent ductus venosus with persistent communication between portal vein and IVC. And you can see conjugated bile is kind of hovering, elevated, then increased to 5.7, but then again came back to 3.5 with mild elevation of bile acids. What we have on the biopsy here is mild inflammation in the portal tract. There is mild ductular reaction. We do have a preserved duct, so artery, vein, and some preserved ducts in the biopsy. Not much lobulitis, but the sinusoids do appear kind of little dilated and variable dilatation of the sinusoids. There is mild cholestasis in zone 3, and again, overall, not much fibrosis in the biopsy. And I think this was 2 weeks old. Okay, sorry. So at 2 weeks, BA can have less fibrosis for sure. But then, there's no bile plugs and there's not much ductular reaction. It is still mild. Not much cholestasis here within the lobules, some in zone 3. So BA remains in the differential. I think it would be very hard to rule it out completely just based on this information we have. It would still be a little, I would say, considered with a caution because ultrasound did not show a small or a hypoplastic gallbladder and the CVD was visualized. And so, I would still consider it with caution. And then some of the additional stains here. So CK7 is showing some ductular reactions, so it's not absent, definitely. EM did not show Biler's bile, BSEP was normal, MDR3 was normal, there is no elevated iron, PSD is just showing Kupffer cells, no periportal abnormal globules, but look at glutamine synthetase, sorry, it's a typo, sorry. So the normal expression of glutamine synthetase is perivenal or zone 3. So hepatocytes around the central vein should show staining by glutamine synthetase, and the rest should be all negative. And what we are seeing here is this diffuse blush in the biopsy by glutamine synthetase. So based on this staining and the fact that we have this finding on an ultrasound examination of a persistent communication between the portal vein and the IVC, basically this is an excellent example of congenital portosystemic shunts. Extrahepatic shunts, they're also called Abernethy malformations. They can certainly present with neonatal cholestasis. So I think the challenge in these patients is not to say is cholestasis because of the shunt, because I think there is always a component of cholestasis that will be because of the shunt. The challenge in these cases is usually the clinicians will say, oh, we know there is a shunt, so we know that we should expect some degree of cholestasis, but is this BA in addition? And we have had some cases of both, congenital portohepatic shunt with BA, and those are very challenging. Those really are very challenging, and we all sweat a lot on those cases. And biopsy can help when the features are classic for BA, but when the features are not classic for BA, in that case, we are just honest. We will say no features of extrahepatic biliary obstruction identified on the biopsy. In those instances, if they feel it is important, they will still go ahead with an IOC. That has happened. And we have had both kinds of results. Like there have been cases where IOC did show a non-draining cholangiogram and it was BA, and there have been examples where IOC was draining. And at that point, we're like, okay, consistent with the biopsy. And so the cholestasis can be explained by shunt. The problem with that is there's really not, extensive literature on how much cholestasis to expect based on the type or the location or the size of shunt. There's always some ideas, but especially when the jaundice doesn't resolve over time, or that is when the team starts worrying. And the shunt may or may not resolve over time. It just depends on the location and size. But important to know when working up a neonatal cholestasis biopsy. Okay, so this is a slightly older child, but again, this can certainly present in the age group like, up to 3 months age. And if you are savvy, I think you have probably noted these abnormal periportal globules with some inflammation, with or without ductular reaction in some cases, but, certainly very abnormal periportal globules. Which are highlighted on PSD, and electron microscopy shows dilated ER with these inclusions within them. So, a very nice example of alpha-1 antitrypsin deficiency. In this case, it was a ZZ phenotype. We always, we don't have to tell them, they do it, but our clinicians always do pie typing before Kasai, because first of all, this mimics BA really very closely, and second of all, we all have seen examples of BA with alpha-1 antitrypsin deficiency, and then there have been even reports on how this subset of BA patients can have particularly poor prognosis with coexisting alpha-1 antitrypsin deficiency. What is interesting about PI-ZZ phenotype, the ZZ phenotype, is that we still don't know what to expect. Like just 2 weeks, maybe a month ago, I had an explant of a 80-year-old girl with a ZZ phenotype with advanced liver disease, fibrosis, who had a grandmother with the same phenotype, perfectly normal. So, so that's a very interesting thing about the ZZ phenotype, is that we still don't have real good knowledge on genotype-phenotype correlation for alpha-1 antitrypsin deficiency. There are some pitfalls for alpha-1 antitrypsin deficiency. It is an acute phase reactant, so serum values can increase during inflammatory states. Heterozygosity is common in Caucasians, so doesn't necessarily rule out other causes of cholestasis. PSD globules, this is important. It may not be present in infants less than 12 weeks of age. Very important. And so, negativity of PSD does not rule out alpha-1 antitrypsin in young babies. Positivity definitely helps. Negativity doesn't rule it out. Extremely challenging to differentiate from BA. Can have a small biliary tree due to disuse atrophy secondary to cholestasis, so can be confusing to surgeons. May have a non-draining IOC, confusing to IR. May have cholestasis, bile plugs, rarely ductular reaction, can be confusing to pathologists. So always do pie typing before Kasai, and then some, 10% infants can present with paucity, duct paucity. This is a fun example. I have to say these are not my pictures. I haven't seen a case so far, but this is just a fun example of a diagnostic pitfall for these globules. Note that they are not particularly periportal, but you see them, and this is a newborn presenting with umbilical bleeding and elevated liver enzymes. On PSD, they don't have a real good appearance of, they have a little bit of a variable appearance on PSD. This is an immunostain for fibrinogen, and this is a very specific pattern on electron microscopy, and so this is hypofibrinogenemia. So just a fun thing to know to differentiate this glob. So not all globules is alpha-1 antitrypsin. I guess that's the learning lesson. And some have gone into the details of the morphology of the globules. And there are, I think, some reports on how these globules differ from alpha-1 ATT. I find it very difficult mainly because alpha-1 antitrypsin itself has a wide variation in the globule morphology. And actually this previous slide was where you see here, this is a globule, this is a globule, this powdery stuff is all globule. So wide variation, so it's hard to kind of go by the morphology. So this is a 2-week-old former term male with direct hyperbilirubinemia. Total bilirubin was 1.6, and on day of life 13, progressed to 3.6. Conjugated bili was 1.9 on day of life 13. So 1.9 and 3.6 at day of life 13, definitely abnormal. This was a normal pregnancy and birth history. breastfed, normal stools, normal cholangiogram, so important here. Chest X-ray cannot rule out butterfly vertebrae. GGT is elevated, we saw conjugated bile is elevated, M allele on pi typing, and bile acids are elevated. So minimal lobulitis here, very mild extramedullary hematopoiesis in some areas. There is some lobulitis here, not much fibrosis, mild cholestasis, portal tracts are identified, bile duct, hepatic artery, portal vein, not much ductular reaction, no bile plugs, no edema, not much portal inflammation. So it's not a portocentric process. There is whatever activity we have, it's in the lobules, right? Minimal lobulitis, mild EMH. CK7 shows that a bile duct is preserved and not much, ductular reaction and not much fibrosis at all. No copper, no PSD globules, BSEP and MDR3 was normal, no Byler's bile, and interestingly, bilirubin recovered after the cholangiogram. So, that can happen with these babies. Sometimes they'll send a biopsy and they'll do a cholangiogram same day or next day. Sometimes they don't wait for the biopsy reports. I think this was a case in this baby, and the bilirubin normalized after the cholangiogram. So this is sort of a buzzword when bilirubin normal. It's like cholangiogram acts as a therapeutic intervention. And this is where essentially, we're talking about biliary sludge, meaning there was not real obstruction, but maybe the bile was less, like more viscous and just inability to drain the bile in a normal manner. And so cholangiogram helped. And in this case, there was HBS trait on the newborn screen. And so the hypothesis here was that the sludge was because of the HBS trait. This has been reported in HBS babies, neonatal cholestasis. So again, something to keep in mind, and just shows how much of close clinical correlation we need on these biopsies. Here is another example of a full-term baby boy, conjugated hyperbilirubinemia, normal GGT. So I'm going to keep BA low in my list of differentials. On day of life 2, you have significant AST, especially compared to ALT, right? So ALT is, it's normal, but AST is elevated. So there's disproportionate elevation of AST. But on day of life 19, they sort of, they're both elevated, and the difference between them blunts off. And there is a normal ultrasound. So with normal GGT and a normal ultrasound, I'm going to keep BA low on my differential. And we will come to this specific finding of AST, ALT elevations at different ages. So here is the biopsy. You're starting to see a definite hepatocellular injury. So you have lobulitis, clearly nice cellular injury, some giant cells, multinucleation. So this is a real good example of basically neonatal giant cell hepatitis, cholestatic. And you have significant EMH. So whenever there is extensive EMH, always think it like ineffective erythropoiesis or some cause for bone marrow stimulation, like can happen with infections or sepsis, but we have significant extramedullary hematopoiesis in the liver. And this is a term baby. So, for a almost 2-3 week old term baby, you should not have this degree of extramedullary hematopoiesis in the liver. Not much fibrosis. Again, I think given all the features, we can agree that BA is going to be very low on the differential, and you're going to look for other causes for cholestasis. So what is important, and I did not mention in the history, is that mom was O negative and the baby was A positive. So there is this Coombs positive neonatal jaundice with ABO and RH incompatibility. And this is a classic biochemical abnormality where the AST-ALT difference typically blunts at 2 weeks of age in neonatal hemolysis. and which is observed in this patient. So, around 2 weeks, this is little over 2 weeks, but around 2 weeks, the difference is blunting off. This is very typical for neonatal hemolysis. In this case, due to ABO&RH incompatibility, it was called inspissated bile syndrome in the older literature, and it's hypothesized to be caused by biliary accumulation secondary to overproduction. So coming to this, the chart that we saw on some of our early slides, ineffective erythropoiesis, that's what it is, just overproduction leading to cholestasis. So we are going to quickly see some examples of cholestasis with steatosis in the newborn period. 6-month-old with failure to thrive, vomiting, abdominal distension, elevated liver enzymes. What you have is macro and microvesicular steatosis. More importantly, we have significant fibrosis, right? So cholestasis and marked fibrosis. So steatosis, fibrosis, cholestasis, this combination in a young age, this is another immunostain that we often find helpful in this particular context. It is fumarate acetoacetate hydrolase. This is the normal expression on the hepatocytes is positive, meaning normal hepatocytes will stain for FAH. In this patient, there is complete absence of FAH on this liver tissue. That led to, some biochemical investigations showing elevated succinyl acetone in urine, elevated tyrosine. Imaging showed a multinodular liver with multiple masses, and patient underwent transplant at 2 years of age. This is the transplant with a, clear nice cirrhosis, multiple nodules with one nodule showing an HCC, and this is very classic for tyrosinemia, hereditary tyrosinemia. So I won't go into the details of this disease. I think you can read that in the textbooks, but what is important is steatosis, fibrosis, cholestasis at young age. Always think of tyrosinemia. Looking at some other examples of cholestasis and steatosis. So this is fat accumulation in the hepatocytes. This is an all red O stain that shows fat with red, and electron microscopy shows fat globules within the hepatocytes. And so this is pretty classic for, it's classic for lysosomal acid lipase deficiency, but the clinical manifestation can differ. And what I mean by that is at the most severe end of the spectrum, you have Wolman's disease. Death usually occurs in the first year of life with hydrops, congenital ascites, hepatosplenomegaly, abnormal neurologic development, to CSD, which is the cholesterol ester storage disease, both occurring because of the same enzyme. One is complete absence of the enzyme, and the other one shows reduced activity. And in the milder form, can present at any age with hepatomegaly, variable splenomegaly, and with portal hypertension or lipid retention. Neonatal macrovesicular steatosis almost looks like NAFLD, of adults, so that pattern in neonates or with, can present with cholestasis again, but NAFLD-like pattern in neonates. Always think of hereditary fructose intolerance, and in unusual instances, malnutrition can present like that. And malnutrition as a cause is really becoming uncommon, but I have actually seen one case here at TCH. These are some classic examples where you can have fat within the hepatocytes and concentrically laminated myelin figures. I think these are some spot questions that we often see in our examinations or board exams, Niemann-Pick disease, multiple types, can present as congenital neonatal cholestasis. This is where you see this pale crumpled tissue paper appearance in the Kupffer cells. So hyperplasia of the Kupffer cells highlighted by CD68. PSD showing bright pink Kupffer cells and pale histiocytes. So Gaucher again can present rare, I would say, as neonatal cholestasis, but can certainly happen. And so This is, the workup for neonatal cholestasis actually is pretty extensive. I think, it really includes not just the pathology understanding, but even the hepatology or neonatology understanding of various processes that can happen around before or after birth. So review of maternal records, birth history, drugs, routine labs, liver panel, family history of liver disease, infectious workup, chest x-ray, ultrasound abdomen, pie typing, a thorough clinical examination for abnormal feces, malformations, bile acid elevations, urine organic acids, if there are any therapeutic interventions, especially TPN, and then going from HIDA to biopsy to IOC, usually in that order. This is how we process and triage liver biopsy at TCH. So we get usually, and this is ideal, I would say ideal does happen in more than 95% of our cases. Occasionally we will have some issues, especially with very small, premature babies. We may not get 3 cores, we'll only get 2 cores, and then it becomes challenging. But usually we'll get 3 cores of liver tissue, 18 gauge needle, reasonably long, 5 millimeters if snap frozen and preserved in a cryo vial that goes to a biorepository. We save it for anything that could happen in the future, any, grants, projects, mostly for research. 2 millimeters piece goes in 10% glutaraldehyde for EM. We have a very active EM lab. And like I said earlier in the lecture, we'll embed and hold at the time of grossing, and will only request full EM if necessary. If it is pertinent, like if it is a sick baby, there are other signs, clinical labs that are suspicious for infection, tissue PCR is sent for various viruses. If it is relevant, sometimes the clinicians will order it, sometimes we order it. Remaining entire goes for histology. We do 16 levels, 1, 9, and 16 get H&E, and level 5 gets a trichrome, the rest remain unstained. We don't do other strains routinely, like retic, iron, PSD, we don't. We'll only do them, as and when required. So our default stains are only H&E and trichrome for liver. We talked about the genetic panel a little bit early on. It's a challenging decision because you definitely want access to a genetic panel. Having it in-house certainly helps with very close collaboration, understanding VOUSs. So I have had so many cross communications between the geneticist where the panel will come back with the VOUSs, but I would see histopathologic change that would go with the VOUS. One real great example is actually VOUSs related to the PKDN gene, so ciliopathies. Otherwise, there will be nothing. The patient would be normal for, PKDN abnormalities, but we would see ductal plate malformation in the biopsy. And so there's always a question like, is it truly a VOUS? Because we are seeing a phenotypic change, so it could be uncertain significance only till the literature comes out. So I think definitely helps with phenotype-genotype correlation to have a good genetic cholestatic panel. And to your point, somebody was asking about the list of genes. I really feel I should have probably put our list of genes here, but if you want to know the list of genes, please email me or maybe contact the organizers, and I'm happy to provide our list of genes that's going to go in the panel. And then, as much as we dislike, no talk is incomplete without COVID. So I don't want to go into too many details, but this is an immunostain for ACE2 receptor, and see how it specifically highlights the luminal aspect of the biliary epithelium. And this is one of our biopsies that were done for neonatal cholestasis. And I just want to show this is that the biliary epithelium is certainly a target cell. Doesn't mean COVID will affect it in each and every case. And I'm yet to come across definitive cases of COVID really affecting the biliary epithelium or causing duct injury, but just, I guess, something to keep in mind, and maybe probably needs more studies. That's it. So maybe we can take questions now.
So Kalyani, there is a question related to that Abernethy case. So did you do D240 IHC in that case, and how were the portal veins? So like most of the time clinicians, they know that it is Abernethy, and then they ask whether it is complete or incomplete. So what is the type, so that they can actually plan the treatment.
Oh, I see. So yes, D240, we did do D240 in this case, and we do D240 on a good number of cases that come with this suspicion of, either suspicion of or documented congenital portohepatic shunt. In my experience, it is definitely a useful stain, but the findings can be patchy. Some portal tracts will show beautiful, lymphatic proliferation, mild dilatation, and the lymphatics are nicely highlighted by D240. One may or may not see that in each and every portal tract. I think, and here I could be wrong, but I think the portal veins don't stain by D240, and at least that's how I interpret it. The negative vessels by D240, the dilated negative vessels by D240, usually I interpret them as portal veins, and they may show other features like dilation, herniation, collateral development, things like that. So it is helpful, and we have done D240 and good number of our biopsies. As far as complete or incomplete, our clinician, I think it's hard for us as pathologists, I feel. I think the best people to give that answer are actually radiologists. So and actually I would like to know, like, do you have any features that you would, pathology features that you would use to differentiate complete and incomplete? Because I don't think
No, actually it is very difficult, and sometimes they keep on asking. Like it is patchy, so in some portal areas you may see, you feel that there are veins. So D240 IHC helps, and I feel it very difficult actually to make out the type.
I agree. Yeah.
So that's why I asked you. And it is uncommon also. So we do get like once or twice in a year. So that way, biopsy, because it is not an indication like for a biopsy.
Right. Exactly. And to your point, because it is so uncommon, I just don't think we have a good knowledge of the spectrum of normal. You know what I mean? Like, so once we understand how D240 really should look like in normal biopsies, or that may help. But again, I'm skeptical. It will help in documenting the features that go with a congenital portosystemic shunt, but I'm not so sure if we can help them with complete or incomplete.
Another difficulty which we face is regarding this paucity of the bile duct. So like you showed a case with prematurity, so I also remember, so that kind of cases. So when we get the biopsy at very less age, so I don't know whether actually to comment, and it is hard to find difficult, completely developed bile ducts. So like you told that they develop up to the 2 years. So once I read so much, because I was not able to find the bile ducts in a case, but there were no other findings which were helping out. So it was looking normal, but just the bile ducts were not there. And that was like 1 month of age. So I read about the development, that how much it is, so whether we should comment or not. So that is a very difficult area. So at what age we should comment that, yes, this is suspected LHLA, or whether there is a paucity due to some other cause or not.
I see. Okay. So knowing that, child is full term, knowing that the child is not small for gestational age, so not growth restricted or IUGR, things like that. So that's important. So what to expect. And knowing, hopefully your biopsy, should be obtained from a reasonably deeper parenchyma. So all these things go into the interpretation. But if you do have a very young baby, especially a premature baby, otherwise everything is normal in the biopsy and you do not see normal number of bile ducts in the biopsy, at that point, the way we word our reports is that, we will say either, so two ways, we say immature bile ducts identified, see comment, or we will say loss of bile ducts, see comment. And the way the reports are structured here, you have a final diagnosis section in the report where these sentences will be in the final diagnosis, and then you have a comment section to the report. And so in the comment we elaborate and we say that we are not favoring, at least given all the clinical context where the baby might be small or too young. You can say that these are all the possibilities, and this may be physiologic, and it may just need monitoring. So you will not pull the trigger, pull the plug on bile duct paucity at that point with the amount of clinical information you have.
Thank you, Kalyani, for such a wonderful talk on such a difficult topic, actually. So I personally find it very difficult. So I think we have answered all the questions asked by the attendees. So I'll call Venkat sir to conclude the session.
Sure.
Thank you so much, Kalyani. That was indeed fascinating. I last did pediatric liver medical biopsies 25 years ago in Birmingham Children's Hospital, and I haven't seen them after that. Things have certainly come a very long way, both in morphology, immunohistochemistry, and molecular biology. And I must say that you managed to compress all of that into an extremely informative talk. Thank you so much. You will be happy to know that many of our alumni like Ranajoy Ghosh and Prashant Durgapal, Sri Gopal Sharma, Nadeem Tanvir, etc., whose term as residents might have overlapped with you, have sent you their compliments on your great talk. I again must thank Dr. Rajni for her excellent moderation. And I must say that the discussions you had between the two of you were extremely engaging and very informative. Before I conclude, I must thank a great team which has put these webinars together. Dr. Chitra Sarkar, when she was head of department, is the person who initiated these webinars. And it is focused on the alumni of AIIMS who are doing so well in life after leaving the Department of Pathology. Dr. Rumare and Dr. MC Sharma have been a constant source of support. The great webinar team which brings these webinars to you is composed of Dr. Anchal Kakkar, Dr. Kavneet Kaur, Dr. Aruna Nambirajan, Dr. Ruchi Rathore, and Dr. Madhu. Many of them, Kalyani, you have met. I thank you all. And with this, we'll bring this webinar to conclusion. Thank you.
Thank you all so much. It is incredible opportunity, and I am so grateful to share this with the whole team and everybody in the audience. So it's truly my pleasure. Thank you.